let us proceed with the Young Investigator session. May I please take the honor to invite the chairpersons and the judges for this session. Dr. Premasi Skar, Dr. Vivek Saraswat, Dr. Anil C. Anand, Dr. Govind Makharia, and Dr. Ashish Goyal.
So there are already some studies available in literature with regard to the proteomic fatty acid and mRNA profiling of adipocyte EVs. But what is not there in literature or in research is whether there are potential profibrogenic or antifibrogenic EVs from adipocytes which is capable of activating stellate cells. So with this cartoon will give you a basic idea, like what are EVs, that is extracellular vesicles, all about. So these are all small membrane-bound particles which are released by cells into the extracellular environment. So basically between 30 to 150 nanometer in size. Thing is that it carries information in the form of protein, lipids, RNA, DNA, etc. So this is what, in a nutshell, I have made a cartoon where, like we want to understand how this extracellular vesicles, basically from mature adipocytes, is able to drive healthy liver to various stages of liver diseases. So today's talk presentation, I'm going to concentrate on whether the fatty liver is going to drive by these fibrogenic cargoes for towards fibrotic liver. So the aim is to profile the fibrogenic cargoes from mature adipocytes, determining the profibrogenic potential of the adipocyte-derived EVs on stellate cell activation using a well-established human stellate cells called LX2 cells, and also an experimental model of high-fat diet-induced obese mice. So this is a simple workflow, the cartoon. So basically, everything will start with transdifferentiation of adipocytes, taking the conditioned media, extracting the EVs, characterization, and further subjecting them to whole exome transcriptome analysis. So where we have found a distinct pattern of cargoes. And we further tested it on stellate cells to see whether it gets activated and what is the percentage of activation between pre-adipocytes and mature adipocytes. And further, we validated the profibrogenic potential using animal model. So this is a initial data. So the a standard transdifferentiation protocol where we have taken the murine fibroblast. It has been stimulated with IBMX dexamethasone and further maintained in insulin media for 26 days to enrich EVs. Further, the characterization was conducted using a gold standard oil red and bow DP staining. So you can see a very well developed lipid droplets and complementary immunofluorescent staining with bow DP stain. And we further validated the expression of key fibrogenic proteins by Western blot, and also the mRNA expression was validated by real-time PCR. The markers such as perilipin, adiponectin, PPAR, gamma, leptin, GLUT4, everything has been very significantly upregulated, and the complement Western blot data is also enclosed. With regard to the characterization and extraction, so we have modified the protocol, the ultracentrifuge protocol. So we have concentrated the media and further extracted the EVs using kit method. And this slide will give you an idea, like the extracted EVs, the size which is between 100 nanometer. And further characterization was done using TEM analysis and Western blot analysis. A classical cup-shaped vesicles is evident from both the EVs extracted from pre-adipocytes and mature adipocytes conditioned media. And the Western blot analysis was also showing that the extracted component is an EV, because the EV marker CD9 is very much evident. With regard to the whole exosome transcriptome signatures, so what we have done, we have subject them to whole exome sequencing, and you can see the PCA plot gives a significant data, about 95% variance between the two different groups. And this is a volcano plot which gives you an idea, like what are all the top hits, so which I summarized in this slide the top 25 upregulated and downregulated genes, and you can see the distinct pattern between the pre-adipocytes and mature adipocyte derived EVs. In a nutshell, this table will give you an idea the major upregulated genes and downregulated genes. The highlighted one are all adipokines, which has been well established. There are few significant leads that we have got, something like resistin or CDAC, which has not been further well studied for pro-fibrogenic potential towards stellate cell activation. So the next thing what we did, so we have subject them to treatment with the stellate cells. So we procured stellate cells from Professor Friedman in MSSM New York. So we first initiated with identifying the ideal dose using cytotoxicity assays, and you can appreciate that up to 300 microgram there was no cytotoxicity of these extracted EVs on stellate cells, and we ensured that the stellate cells what we got as entered the cells by subject them to a special stain called DIO staining. DIO is a lipophilic fluorescent dye which will stain lipids. So you can see that both the PA and mature adipocyte EVs are entering into the cells. And these are all the key fibrogenic and inflammatory markers. So one can see the treatment with mature adipocytes as significantly upregulated the fibrogenic markers like alpha SMA, collagen A1, and also inflammatory markers TNF alpha, interleukin 6, and NF kappa B. This is the preliminary data, but we are awaiting this mRNA-seq analysis, and that is what pending. So with regard to Western blot, alpha SMA, collagen, and NF kappa B P65 fraction is also upregulated in treatment with mature adipocyte EVs, which was encouraging. And further, what we did, we subject them to animal study. So here we have developed a model, standardized model in our laboratory. So where we have used 60% kilocalorie diet, high fat diet, and it was left for 16 weeks. And then based on the body weight and glucose, insulin, so we have further segregated into 4 groups: control diet, high fat diet with PAEVs, high-fat diet with MAEVs. So here we administered the EVs by tail vein injection at a concentration of 100 microgram per kg body weight based on our pilot study. So this slide will give you an idea all the EVs, both the EVs has shown a moderate to significant effect on level of cholesterol, triglyceride, liver markers, and histological evaluation. You can see a classical steatosis in high fat group, which is in the lower panel. And what we expected and data is that these mature adipocyte EVs is driving this liver towards fibrosis, which is very much evident from the infiltration of cells. This is just a representation of a slide. And collagen also examined by picrocereus red staining and hydroxyproline assay, so which also favors the stellate cell activation and fibrosis acceleration. And markers alpha SMA, collagen A1, TNF alpha, NF kappa B were all upregulated, but still we want to confirm it using mRNA sequencing, which is still pending. And the Western blot data marker for stellate cell activation is highly increased in high fat group, similar to that of mature adipocyte EVs, has shown a very significant difference. In summary, so we could able to first demonstrate the whole exosome transcriptome analysis, which provided a distinct pattern of cargoes between pre-adipocytes and mature adipocytes. And mature adipocyte EVs activated stellate cells in culture conditions, and also it accelerated liver fibrosis in an experimental model. So what's next? So we are planning to already started a long duration study with mature adipocyte EVs to see whether it can still aggravate and lead to cirrhotic or cancer model. And with regard to enrichment, so we are already started enriching specific EVs like resistin, CDAC using antibody affinity magnetic beads, and we want to delineate its pro-fibrogenic potential. And also we have planned and initiated the collaborations for starting the liver organoids. To very important slide, acknowledgement. I would like to acknowledge Dr. Anbarasu Kannan, who is the collaborator for this study, and Dr. Vengat, who is my second PhD student, and Mr. Sachin, who is a project JRF, who helped in this, getting the things done. Thank you so much. And I'll be more happy to
Well,
take suggestions and also questions. Thank you.
Dr. Madan, thank you for that presentation. But I think you overshot your time quite significantly. So, what we can allow is just one quick question and a quick response from you.
Thank you, sir.
Good morning.
Good morning, sir.
Excellent presentation. How does this relate to human steatosis and steatotic changes? Because this is all in the mouse. Is there anything that can show us that this could also be operative in humans?
Yes, sir. So I have not shown some data where like we also done the same kind of study using immune fibroblast, and we have shown that the EVs derived from mature adipocytes from human fibroblast is able to activate stellate cells, and in literature also like the from the earliest speakers in the last 2 days. So they have shown that the adipocyte tissue inflammation is will drive liver fibrosis. But the missing gaps is that like what are all the cargoes very specific that can be taken up as a profibrogenic markers.
Thank you.
Thank you, sir.
Okay, thank you.
Thank you.
I think we move on to the next presentation in this Young Investigator Award session. And I invite Dr. Ashwin Vinod to speak to us about rifaximin plasma exchange and GCSF with standard medical therapy versus standard medical therapy alone in severe alcoholic hepatitis, the GRACE AH randomized controlled trial. Dr. Ashwin.
Just a quick announcement. The presentation is for 9 minutes and then the discussion will be of 3 minutes. Thank you.
Pointer is not coming. So I will start. I'm Dr. Ashwin P. Vinod from recently passed out from PGI Chandigarh. Would be presenting the findings of GRACE AH randomized control trial, which is rifaximin, plasma exchange, and GCSF with standard medical therapy versus standard medical therapy alone in severe alcoholic hepatitis. So severe alcoholic hepatitis is a dreaded disease with a very high short-term mortality, and it has a multi-axial disease pathobiology. We have very few therapies and strategies in our current therapeutic armamentarium against severe alcoholic hepatitis. The list of therapies which have failed in severe alcoholic hepatitis is very long. So what could be the reason why so many therapies are failing in severe alcoholic hepatitis? One reason could be the multiple axes of disease pathophysiology, like gut dysbiosis and oxidative stress and immune paralysis along with the cytokine storm. So the multi-pathway pathogenesis could be targeted by a multiple agents rather than a single agent targeting a single pathway. So what is the role of combination therapy in severe alcoholic hepatitis? Since no single drug can target these multiple pathways, the need of the hour is to target these multiple pathways with the help of combination therapy. So data is coming up in the recent time showing the efficacy and improvement in a relevant clinical outcome in patients with severe alcoholic hepatitis. So the combination therapy in severe alcoholic hepatitis is supported by the mechanistic rationale, clinical data, and expert review. So what is the role of rifaximin therapeutic plasma exchange and GCSF in severe alcoholic hepatitis management? Rifaximin help in controlling the gut-derived endotoxemia. Therapeutic plasma exchange helps in washing out the cytokines and the toxins which are present in the blood. And GCSF will help in stimulating the bone marrow, leading to stem cell mobilization and also help in immunomodulation. So my hypothesis is a combinatorial approach which involves the administration of rifaximin, therapeutic plasma exchange, and GCSF alongside standard medical therapy could address multiple pathogenic axes of this severe alcoholic hepatitis. And to evaluate, my aim would be to evaluate the efficacy of above combinatorial therapies compared to the SMT. Outcomes, the primary outcome was to assess the survival at day 30, and secondary outcome was to assess the survival at day 60, 90, dynamics of disease severity scores, organ failures, and incidence of infections. The study was conducted as a single center parallel group open label randomized control trial over a period of 12 months at the Department of Hepatology PGI Chandigarh. The inclusion criteria were adult patients with a diagnosis of severe alcoholic hepatitis who were showing failure to improvement with a SMT over a period of 1 week, and the key exclusion criteria were enlisted. So I would discuss about the methodology of this study. After assessing potential candidates of severe alcoholic hepatitis, we observed them for at least 1 week to rule out that the patient was spontaneously improving. After that, the patient were randomized into 1:1 allocation into the standard therapy group and the combinatorial therapy group. In the control group, that is the standard medical therapy, all the patients only received the INASL guideline-based standard medical therapy. In addition to standard medical therapy, the intervention group also received rifaximin for 30 days at the dose of 550 BD. 3 to 5 sessions of plasma exchange was given from day 1 to 5, followed by GCS of 10 doses of injection from day 6 to 10. The sample size was calculated from the data which we derived from the previous literature. We found out that at least 35 patients per arm was sufficiently powered enough to find the statistically significant difference between the primary outcome of the groups. The statistical analysis was performed using various tests like Fisher's test, Mann-Whitney U test, McNemar test. Survival analysis was performed using Kaplan-Meier curves, and hazard ratio was calculated using Cox model. A multivariable Cox model was also used to adjust for confounders. Longitudinal and mechanical markers like the blood-based biomarkers were analyzed using a linear mixed defect model. So this is a console diagram. After randomization, 1:1 into the 2 groups, during the follow-up, 2 patients from each group were lost to follow-up, but at the end of the analysis, we analyzed all the 70 patients as per the intention to treat analysis. This is the baseline variables table. We can see that all the baseline variables were matched between the 2 groups. So coming to the key primary and secondary outcomes. So the survival was significantly higher in the intervention group when compared to the control group at different time points. Here we can see at day 30, the hazard ratio was showing a trend towards significance, but at day 60 and 90, it was statistically significant. If you look at the cumulative mortality, the chances of higher mortality was in the interventional group compared to the was higher in the control group when compared to the interventional group. So this is a multivariable Cox regression analysis where we looked into the effect of baseline MDF, MELD, and CLIFC-OF. We found out that even though initially the hazard ratio was only attaining trend towards significance, after adjusting for the baseline MDF, MELD, and CLIFC-OF, we found out that the significance have improved. So here come the results of infection. The mean time to infection development was longer in the interventional arm when compared to the control arm. There was lower infection rate, and the infection-free survival outcomes were also better in the interventional arm. If you look at the dynamics of the disease severity score within the group from initial assessment to the last assessment, we can see that there was a significant improvement in MELD, CLIFC-OF, and MDF in the interventional group, but such significant difference was not seen in the control arm. If we look at the delta severity score category, we can see delta MDF was significantly improving in patients who are allocated to the interventional arm, and other disease severity scores, delta score was attaining a trend towards significance. This alluvial diagram is showing the evolution of organ failures. A higher proportions of the patients in the organ failure at baseline in the intervention arm showed an improvement in their number of organ failures. Conversely, a significant proportion of patients in the control arm were worsening at the last assessment. So this is a table of adverse events. All therapies were well tolerated with no discontinuation of the therapy. The adverse reaction, if developed, were mild, and there was no significant difference among the rates. So these are the results of the biomarkers. So we can see there was significant improvement in LPS levels, von Willebrand factor levels, RIPK3, GAS2 level, and M30 levels. These are the biomarkers which looked into the markers of cell death, inflammation and bacterial translocation, and vascular injury. So to summarize the key findings, at different time points, the survival rate in the interventional group were considerably higher in the intervention group compared to the control group. And this survival benefit persisted even after adjustment for key baseline prognostic indicators. The intervention also led to improvement in the infection, reduction in different disease severity scores, and improvement in stem cell mobilization. There were also significant important improvement in the biomarkers also, which marked the marked the inflammation and translocation like LPS, endothelial injury, and cell death markers. The strength of the study, this is a first proof of concept trial in assessing the role of this combination in severe alcoholic hepatitis. It had a randomized controlled design, blinded endpoint assessment was there. It comprehensively evaluated both clinical and mechanistic outcomes and added robustness due to intention to treat analysis and baseline confounders were adjusted using a multivariable Cox regression. Limitation, it was a single center open label trial design. Further multi-center study is needed for generalizability, and in this case we couldn't go for a blinded trial because of the interventions involved. An adaptive RCT would have been more robust. To conclude, this first human proof of concept study showed significant survival benefit in patients with severe alcoholic hepatitis. And future prospect would be assessing combinatorial therapy in different permutations and combination, and to assess adaptive trial design. And that concludes my today's topic. Thank you. The dais is open for questions.
Okay. Thanks, Dr. Ashwin. Then open for questions. Yes, Dr. Rakesh.
Thank you, Dr. Vinod. If I recall right, your sample size calculation was based on 29% survival in the SMT group and 66% survival in the treated group. That means you thought that the patients you would select without additional treatment, only about 29% would survive. And that was 30-day. What you actually found, the 30-day survival in your SMT group was 75%
Yes.
plus. How do you explain this beautiful survival in this group of patients when you did not expect that to happen? Second, the major difference in 30-day survival was not statistically significant, only after adjustment.
Yes, sir.
In a randomized controlled trial, we expect that all factors have been overall balanced between the two groups. And most people would not accept adjustment in a randomized controlled trial because you are adjusting only the some variables and you are not adjusting for other variables that you may not have included in adjustment. Any responses?
Yes, sir. Thank you for giving me an opportunity, sir, for answering this,
it's all yours.
clarifying this. Sir,
Thanks for me
the
getting the
survival,
opportunity.
even though from the study which we used for calculating the sample size, that was Garg et al.'s paper on GCSF survival effect on ACLF patients. But here we can see we took a patient which is very selective, to be honest. These patients were not having any extra hepatic organ failure at the time of randomization. But the previous study, the patients were ACLF group, so there we expect extrahepatic organ failures also, which actually increase the mortality in that group. Here we took a patient profile which was not having any renal failure to begin with, no cardiovascular or respiratory failure, or no advanced encephalopathy. And the infection cohort, the previously infected cohort in our group was also very less. We controlled all the infection, then only we randomized the patient, which did not happen in the Garg et al. Paper.
So my question is, this was not a group of people who needed some additional forms of therapy. The difference in the two without adjustment was not significant, and it is adjustment that is bringing in a difference. So I really don't know whether we can draw much conclusions. Thank you.
So, sir, to avoid any spontaneous
I think
recurrence,
let's
we
move to the next
observed
question. Dr. Vinod, we are run out of time now. Let's have the last question and then we can.
Yeah, I have this question. Well, I have four queries actually. 91% versus 74% survival at 30 days, in spite of developing organ failure, is too high survival as compared to other series. Secondly, 1 week no treatment, that I think is unethical, waiting for 1 week for spontaneous recovery. Third, before jumping on to 3 drugs combination, has anyone tried rifaximin with plasma exchange versus GCSF, or GCSF versus with rifaximin? Has 2 drug combination been tried or not? These 3 questions. One more query, but first you answer these 3 questions, then I will ask.
So the first question is somewhat similar to SARS query only. Here the survival is different because we took a very homogeneous group of patients who did not have any extra hepatic organ failures. The only organ failure the patient had at baseline was liver failure or coagulation failure. There were no renal failure, respiratory or cardiovascular failure.
Even 91% versus 74% survival
we'd
is
like
too
a
high,
crisp
but
responses,
patients
please. We
developing
are out of
organ
time.
failure and follow-up.
Dr. Brijesh, can we continue this discussion off the podium now? He's finished his time for cross-examination and presentation.
The answer was not clear, that's why.
Yeah, but despite overshooting, it hasn't happened. So I think we'll rate things accordingly. Thank you, Dr. Ashwin.
Thank you, sir. Thank you.
I'll now invite Dr. Pinky Juneja from ILPS for her presentation.
Good morning, everyone. I am Pinky Juneja, PhD student at Institute of Liver and Biliary Sciences. First, I would like to begin by sincerely thanking INASL for giving me the opportunity to present my research work entitled as Increased Versican and Fibrosis in Mesenteric Lymph Node Disrupt Immune Surveillance and Drive Systemic Bacterial Dissemination in Cirrhosis. To begin with a brief background, mesenteric lymph node is a very pivotal position in terms of immune anatomy. It acts as a barrier between the mucosal immunity and reminder of the immune system. If we look closer in the function of mesenteric lymph node, so when bacteria crosses the gut epithelial barrier, it is translocated to the mesenteric lymph node via dendritic cells, where they present the antigen to macrophage and T cells for an effective immune response. This process is essential for containing the bacteria locally and preventing further spread. However, in case of cirrhosis, with gut epithelial barrier being already compromised, amylin fails to contain this bacteria. As a result, bacteria translocated to the systemic circulation, fueling further infection and complication. Therefore, we aim to elucidate the mechanism underlying the failure of amylin to effectively mount an immune response during advanced cirrhosis. For this, we first developed advanced animal model of liver cirrhosis using CCL4 till 12th week. At the end of the 12th week, we gave a single shot of LPS. 24-hour post LPS, we quantified the immune response. In the mesenteric lymph node, we observed an increase in the dendritic cells, macrophages, and inflammatory monocyte in the cirrhotic group. Looking at the T cell response, we observed an activated T helper cell response along with an increase in the T regulatory cells. In spite activated immune response in the mesenteric lymph node, we observed a decreased activated T cells along with an increased T regulatory cells in the systemic circulation of cirrhotic rat. Also, we observed a decreased dendritic cells and inflammatory monocyte. We then checked the immune response in the lymph and the portal circulation as well and observed a similar type of immunosuppression. To summarize so far, in healthy rats, mesenteric lymph nodes show a balanced and active immune response. However, in cirrhosis, mesenteric lymph node had both T cell activation and suppression, while the blood and lymph showed decreased activated T cells and more Treg cells, suggesting an overall immunosuppression. We then next checked the bacterial containment capacity of the mesenteric lymph node. For this, we gavaged the control and cirrhotic group with the GFP label bacteria. As you can see, in control, bacteria is retained to the mesenteric lymph node only, whereas in cirrhosis, bacteria translocated via the efferent mesenteric lymph and the portal blood to all the distant organ. So what exactly makes this amylin in the cirrhotic group different from the control group? To answer this, we did the proteomics analysis of the mesenteric lymph node from control and the cirrhosis. What we observed is around 220 differentially regulated protein in the cirrhotic group compared to the control. Heat map shows the expression of top 20 differentially regulated proteins. Volcano plots highlights the upregulated and downregulated protein in the cirrhotic group compared to the control ones. The downregulated protein were involved in cell migration, cytoskeletal remodeling, and bacterial defense. Pathways responsible for the bacterial response or the LPS were also downregulated in the cirrhotic group. The upregulated proteins were involved in ECM deposition, negative regulator of the cell migration, and certain chemokine receptor, of which we identified versican, which is significantly upregulated only in the cirrhotic amylin compared to the control ones, and it is involved in the immune cell trafficking and response. Therefore, we further choose to characterize its role in the mesenteric lymph node of cirrhosis. Versican is an extracellular matrix protein. It is secreted mainly by the fibroblast or matrix producing cells. It interacts with the immune cells and regulates the immune cell trafficking and response as well. In case of inflammatory condition, versican deposition can impair the immune cell trafficking, and immunomodulate the response. So for first, we try to identify the cellular source of versican in the mesenteric lymph node. For this, we sorted and collected the cells of the mesenteric lymph node into immune population, endothelium, and the stromal population. We identified an highest expression of the versican in the stromal population of the control rat, and of these, versican is significantly upregulated in the cirrhotic stromal population. To further characterize the role of versican, we then culture these stromal cells in the presence or absence of versican recombinant protein along with the T cells, and observed a T cell aggregation in the case of versican. To check the phenotypic effect of versican on the lymphocyte, we did the flow cytometry analysis and observed in the presence of versican and LPS, there is a significant increase in the T regulatory cells. On the other hand, there is a slight decrease in the activated T cells as well. Versican also affect the T cell migration via transfer migration assay. We check in the presence of versican, there is a decrease in the T cell migration. So overall, versican, given these immunosuppressive effect of versican, we then next assessed what will be the effect of versican if we inhibit it in vivo. We inhibited the versican expression via an siRNA and observed up to 90% reduction in the cirrhotic mesenteric lymph node. We added the LPS short as well and checked the immune response 24 hours after that. In the mesenteric lymph node, we observed a substantial increase in the activated T cells. Empty staining revealed a decrease in the fibrosis and ECM deposition in the versican siRNA group compared to the control. Importantly, there is a decrease in the endogenous bacterial load in the mesenteric lymph node of the versican treated group. These effects were translocated in the systemic infection with a substantial increase in the activated T cell response. Given the strong immunomodulating role of versican observed in our experimental model, we then checked that if versican levels in the plasma could serve as a prognostic biomarker in decompensated cirrhosis. So we did a pilot study in which we took around close to 50 patients, cirrhotic patients, and checked their versican level. What we observed is a substantial, significant increase in the versican level in the plasma of cirrhotic patient compared to the control. Patient with the culture positive, that is bacteremia, had a significantly increased versican level compared to the culture negative and control. Also, the non-survivor had a significant increase versican level compared to the control. To evaluate its predictive value for the mortality, we performed a univariate and multivariate analysis. In the univariate analysis, all these factors were significantly associated with the mortality. However, in multivariate analysis, versican and HE came out as an independent predictor of mortality. Our ROC curve analysis of plasma versican showed an AUC of 81.6, which showed a good discriminative power. Kaplan-Meier curve also showed a significant difference between the survival between two groups, with a cutoff value of 14.57. Versican above the cutoff showed an 85% mortality, whereas below the threshold showed only 30% mortality. So to conclude, in cirrhosis, elevated versican in the mesenteric lymph node of cirrhosis led to impairment of T cell trafficking, T cell response, as well as bacterial dissemination. Also, versican can serve as a biomarker of MLN failure or dysfunction in cirrhosis and can act as a potential therapeutic target in cirrhosis patient, especially the sepsis related. In the end, I would like to acknowledge Institute of Liver and Biliary Sciences, Professor Sareen, my supervisors, and my lab, also the funding partner from the project and my fellowship, CSM. Thank you.
Thank you, Dr. Pinky, for an excellent presentation. Floor is open for questions.
So, Ms. Juneja, excellent work.
Thank you, sir.
There are multiple things that happen with the immune system in cirrhosis. There are changes in T cells, there are changes in T cell production, function. How do we say what role do changes in the lymph node play in the overall immune perturbations? Because we need to know that before we think that we can tinker with this, as you are suggesting that we should use weak scan or weak can, whatever it is, for therapeutic modulation.
Thank you, sir, for the important point. As I've showed in the background slide, mesenteric lymph node is a very important position. It is a hub of immune cells. So whenever there is any bacteria which breach the gut in cirrhotic condition, if we say, so MLN is only responsible to contain this bacteria. If MLN will not act, this will lead to the translocation. So, and MLN, as we all know, it's a lymph node. It contains all the major immune cells which act to prevent the bacterial translocation.
Yes and
So-
no. There is so much shunting of blood in cirrhosis that the bacteria that come from the gut directly get shunted into the systemic circulation and they don't go out into the lymph and through the mesenteric lymph nodes. We actually have bacteremia, right? So, what role do lymph nodes play? You yourself in your presentation said you saw bacteria in all tissues. Whether they went through mesenteric
Sure.
system or not, we can't say.
So in the gut, there are many players, obviously, but mesenteric lymph node contains all the bacterial origin which arise in the lymph. So all the blood derived origin were controlled by the spleen, whereas lymphatic derived origin of the bacteria were handled by the mesenteric lymph node. And in the gut, there is in the gut, the bacteria majorly transported to the lymph. If we see, yes, via the blood also, but lymph node handles all the lymphatic
Thank
lymph
you.
origin.
Thank you, Dr. Juneja. And can we move on to the next presentation?
I think after three wonderful presentations, the next presentation is by Dr. Sambhav Gupta from ILBS, and he will speak to us on effective supervised and aerobic exercises in those patients who undergo liver transplantation, and this is a randomized controlled trial. Sambhav.
A very good morning to everyone. I am Dr. Sambhav Gupta, and I would like to thank INASL for giving me this opportunity to present the work that I did in Institute of Liver and Biliary Sciences, New Delhi, under the guidance of Professor Vinendra Pamicha. The title was to effect of supervised aerobic and resistance exercises on measures of frailty and postoperative outcomes in adult chronic liver disease patients undergoing living donor liver transplantation. This was an open-label randomized controlled trial. So a little bit of background regarding this. So frailty and sarcopenia is basically found in 17 to 50% of cirrhotic patients and can lead to higher waitlist mortality, unplanned admissions. It can also lead to higher postoperative sepsis, longer requirement of ventilatory support, longer ICU stay, more number of neurological complications, higher post-LT death, and episodes of rejection. There are few ways to tackle it. Few of them are use of myostatin inhibitors, androgen receptor modulators, insulin-like growth factor 1, and exercise. Out of all these, exercise has very well been proven to be of use, but only in compensated cirrhotics. So that is why we chose to use this modality in our subset of patients as well. We had two groups. The intervention group was that of exercise, wherein we gave them aerobic and resistance exercises thrice a week for at least 4 weeks before the transplantation. Then there was a control group that received the standard medical therapy in the form of 35 to 40 kilocalories per kg per day of calorie intake and 1.2 to 1.5 grams per kg per day of protein intake. And the primary objective was to see the change in the liver frailty index, SPPB scores, and the pulmonary function tests. The secondary objective was to assess if there was any change between the two groups in terms of time to extubation, the first time to first bedside ambulation, bipilar ambulation, duration of NIV use, duration of ICU stay, hospital stay, and the post-operative day 15 L3-SMI levels. And there was all the consecutive adult CLD patients who were consenting and were being planned for LDLT were included into the study. However, patients who had a physical disability or were of ECOG 4 performance status or were not able to follow the exercise regimen or were on the following drugs which could actually modify the frailty scores and the sarcopenia were excluded from the study. So from September 2023 until 31st October 2024, we assessed a total of 225 patients, out of which almost 165 patients are excluded for various reasons. And finally, we randomized 60 patients in block size of 6, and we got 30 patients in both the arms. Many patients were lost to follow-up, and few patients also had adverse events during the LT workup itself, leading to mortality. So a total of 4 patients dropped out from the SMT arm and 7 patients dropped out from the exercise arm. And finally, we analyzed 26 patients in the SMT arm and 23 patients in the exercise arm. So the sample size calculation was done assuming that the median LFI of a decompensated CLD patient is 3.9, and we assume that there would be an improvement of 5% in the LFI scores on the follow-up measurements. So we reached a sample size of 54 patients, and assuming a 10% non-compliance, we actually reached a sample size of 60 cases with 30 cases in each arm. The analysis for continuous variables, categorical variables, and the subgroup analysis were done as usual, and the significance was seen at 5% level. Coming to the results, so the baseline demographics in the terms of age distribution, gender distribution, BMI distribution, the etiology, the ECOG performance status, ASA status, proportion of SCC patients, proportion of portal hypertensive patients was comparable between both the groups. Then the number of decompensations recorded and the comorbidities recorded were also found to be comparable. However, of note over here, almost 90% of the patients in both the groups had ascites, and they also had sarcopenia on L3-SMI. And also, that almost 23% of the patients in the exercise group had a prior history of SVP. However, this was not statistically significant. What I mean to say is that we were actually dealing with a very sick group of patients. So the baseline measures of frailty, such as the MELD sodium score, the CTP scores, LFI, SPPB, were found to be comparable between the two groups during the enrollment period. And of note, the mean MELD score was that of 22.5 and 22.9 for the groups. Almost 50% of the patients were CTP C status, and almost 80% of the patients were pre-frail in the study group. The pulmonary function tests were also found to be comparable between both the groups, and there were few confounding factors that we did take care of. There were patients who had a habit of doing exercise even before the enrollment, so we didn't ask them to stop, but we did take care of it as a confounding factor. We also did take care of patients who were taking L-ornithine, L-arginine intake before the enrollment. So these confounding factors are also equally distributed between the two groups. Of note in this particular table, the duration between the first documented decompensation till the first referral for liver transplantation or enrollment to the study was almost 1400 days. That's almost like 4 years. So on the preoperative follow-up as well, the MELD sodium scores, CTP scores, LFI scores, SPPB remained comparable between both the groups. And the pulmonary function test also remained comparable between both the groups. Of note over here, I would like to say, almost 90% of the patients in the exercise group required an emergency admission during the LT workup itself due to recurrent decompensations that they were having, and this was significantly more in the exercise group as well. Intraoperatively, all the parameters are found to be comparable between both the groups. Coming to the post-operative outcomes, this is the primary outcome of LFI change, SPP change, and the pulmonary function test change on POD 15 as well as on POD 30. They were found to be comparable in both the groups. So we went on to do a general linear model for repeated measures with covariate adjustment. We adjusted for preoperative, intraoperative, and postoperative covariates as well, which have been already well established. We found that LFI scores, SPPB scores, and the peak expiratory flow rates on POD 30 were significantly better for the exercise group. Also, we made trend charts for these using the general linear model. These are the trend charts over here. So for the LFI trend, SPP trend, and PFT trends, you can very well see that the red line depicts the exercise group, and there's a difference between the exercise group and the SNT group. So coming to the postoperative outcomes, the secondary outcome measures. So the time to extubation, need for reintubation, the total number of septic complications, 90-day mortality, readmission to ICU, they all were found to be comparable between both the groups. We did make a generalized linear model with covariate adjustment as well, and we found just a trend for shorter duration of NIV support, shorter time to ambulation to chair, shorter time for bipedal ambulation in the exercise group. There was a trend for that. We also conducted few subgroup analysis. The first subgroup analysis was on the basis of exercise-related confounding factors that were present in the patient's pre-enrollment itself. For patients who did exercise before the enrollment, we saw that they had significantly better pulmonary function tests, significantly better L3-SMI levels as well. The second subgroup analysis was on the basis of emergency admissions, requirement of emergency admissions during the LT workup itself. Patients who had such a requirement had worse SPPB and LFT and LFI scores, and that was also statistically significant. Coming to the if there was preoperative culture positivity or not, so a person who had preoperative culture positivity had significantly worse SPPV scores and longer duration to bipedal ambulation and duration of ICU stay. So I would like to conclude by saying that exercise for high melt sodium patients, CTPC patients, is very well feasible, and it came without any increased adverse events as well. However, there was poor compliance because of the recurrent decompensations that they were having and requirement of admissions. Then adding preoperative SARE, that is aerobic and resistance exercises, actually led to better postoperative measures of frailty in our study. Adjusted analysis showed just a trend towards shorter NIV support, bedside ambulation, bipedal ambulation, and pre-enrollment performance status and routine of exercises were good indicators of overall health, and preoperative culture positivity and a requirement of emergency admission actually predicted frailty and delayed the postoperative recovery. Finally, I would like to conclude by saying that patients should be encouraged to attend physiotherapy sessions early on, irrespective of their CTP status. And future directions, a larger study with more number of patients and prolonged duration of intervention should be planned, and adequate preoperative optimization can certainly lead to potentially better postoperative outcomes. Thank you.
Thank you so very much for your wonderful study. I just want clarification that your title says child C,
Yes,
but
sir.
you had patients about child A and child B?
Yes, sir. There were child A, child B as well, but there were almost 50% of the patients were child C status. So this has never been done before. All the studies that have been done with exercise as a prehabilitation have been done in in child A, early child B, and a MELD score of mean MELD score of 7 to 11. That is all. So this is the first study that has been done in such sick group of patients.
And with a small clarification, how long was the session of each session was how long?
Sorry, sir.
How long was the session? You give 5 sessions to each patient. How long was the session?
Session was almost 1 hour long, which included both the aerobic exercises and the resistance exercises. Aerobic exercises were in the form of seated cycling or brisk walking only, and resistance exercises were for all
right.
6-7 groups
Dr.
of
Agrawal,
muscles.
please. Yeah.
Yeah. My question is, what was the counseling that you gave to the control group? I mean, when you're telling this intervention group that we're going to make you do 1 hour of resistance and this exercise, what was the advice that you gave to the control group? Did you just left them as to what they were doing earlier? Is that okay? And secondly, how did you make sure that the control group, did you monitor their activity or steps or something per day or something to see what were they actually doing during the period of observation in comparison to the exercise group?
Okay, so during the moment of enrollment, we made it very sure that we first screened the patients in the OPD so that we knew whether or not the person can do exercise or not. So the screening was just asking them to do the basic exercise if they are able to follow or not. The second thing was if they are able to do a 6-minute walk test without any desaturation or not. Having ensured that, only after that did we tell them that, see, there's a study that's going on, and we are going to randomize you, and you might get randomized to the exercise group or the SMT group, and SMT has been proven to be of benefit in everyone. And exercise is a new thing that is being done for such sick patients. We are really not sure how it's going to be. Are you fine with that? When they agreed to it, only then did we randomize them to a particular group, and then we really didn't face much problems in with the patients being allotted a particular group. They did follow the interventions that were allotted to them.
No, how do you know they didn't change their activity during the period, even the control group?
For that, we did ask on the follow-ups as well, like if they've been doing some exercise on their own or doing some yoga, that we did account for in the confounders as well. And we didn't check the step counts. That's a point well taken, sir. We didn't check the step counts.
Dr. Agrawal, can we skip your question in interest of time? Can we skip your question?
Skip.
Because interest of time, sir, interest of time. Thank you so much for a wonderful presentation.
Thank you, everyone.
Yes. So again, it's my pleasure to invite the last speaker for this session. And the second very interesting study coming from PGI Chandigarh. This is yoga is non-inferior to exercise, being presented by Dr. Balaraj.
Thank you so much, sir. Myself, Balaraja S. I'm DM resident from the Department of Hepatology, PGI Chandigarh. I'll be presenting my work entitled Yoga is non-inferior to exercise in improving hepatic steatosis in metabolic dysfunction associated steatotic liver disease, an open label non-inferiority randomized control trial. So as we know, MASLD is MASLD has emerged as the predominant cause of chronic liver disease worldwide. The mainstay of management is lifestyle intervention, which consists of adopting a balanced, low-calorie diet along with regular physical activity. Yoga is a practice involving specific postures, that is asanas, controlled breathing techniques, that is pranayamas, and meditation or mindfulness, that is dhyana. It works together to enhance flexibility, strength, balance, and mental focus. Previous studies have shown to prove yoga to improve insulin sensitivity, weight loss, and metabolic syndrome. However, no studies have specifically evaluated its effect on improving steatosis in MASLD. So our research hypothesis is that yoga-based lifestyle intervention can effectively modify key metabolic risk factors such as obesity and insulin resistance, thereby shall contribute to the improvement of MASLD. So the proposed mechanism of yoga in improving in obesity is the energy expenditure during the yoga session, improvement in overall flexibility and body strength, contributing to the additional activity outside the yoga session, increased body connectedness, thereby leading to awareness of satiety and the discomfort of overeating, practice of mindfulness, which reduces stress and improves mood and reduces the emotional overeating. So this is a single center prospective open label RCT, which was done in PGMER from July 2023 to December 2025. The inclusion criteria were MASLD with overweight or obesity with hepatic steatosis as measured by controlled attenuation parameter more than 248 on vibration controlled transient elastography with patients aged between 18 to 60 years. The main exclusion criteria were patients on drugs causing weight loss or anti-diabetic medications such as GLP-1 analogs or glitazones and any pharmacotherapy for MASH. So our primary outcome was to look for improvement in hepatic steatosis at 6 months, and the secondary outcome were to look for improvement in body weight, BMI, central obesity, improvement in inflammation, fibrosis, metabolic parameters, and to look for improvement in fatty and sarcopenic obesity. So the methodology was we took the demographics, lab investigation, and anthropometric measurements at baseline and at 6 months. Vibration controlled transient elastography was done, and liver stiffness measurement and controlled attenuation parameter was done, and non-invasive scores such as APRI, FIFOR, NFS, and FAST were calculated. MR proton density fat fraction was done in 20 patients in each group, and patients were allocated into 2 study arms of in 1:1 ratio. That is intervention arm consisting of yoga with dietary calorie restriction and control arm with, that is exercise with dietary calorie restriction. The intervention arm was advised obesity yoga protocol. The duration of yoga was 1 hour daily, 6 days a week. Accredited yoga trainers delivered it in person and as well as utilizing the teleyoga facilities of Collaborative Center for Mind-Body Intervention through Yoga, PGMER Yoga Center. And the control arm was advised moderate intensity aerobic exercises. The duration was 30 to 45 minutes for at least 5 days in a week. All the patients were assessed by a dietitian and advised dietary calorie restriction according to their body weight and according to the local dietary practices. This is the pictorial representation of the yoga protocol consisting of prayer, stretching exercises, asanas, Surya Namaskaras, pranayama, and then again ending with the prayer. So the sample size was calculated based on the previous study with lifestyle intervention. The sample size was calculated as 110 with non-inferiority limit of 0.25 and the power of 80%. So coming to the result, this is the consort diagram. 225 patients were assessed for eligibility, and after excluding 114 patients, 110 patients were randomized into 55 group of 55 each. That is, group A is yoga with dietary calorie restriction and group B is exercise with dietary calorie restriction. 4 patients were lost to follow-up in group A and 3 in group B, and all patients were finally included in the analysis as per intention to treat analysis. So this is the baseline characteristics. As we can look here, age, gender is comparable at baseline. The median weight is 80 kg and the median BMI is 28 kg per meter square. More than 90% of, about 80% of the patient had more than 2 metabolic risk factors at baseline, and more than 60% of the patient had 3 metabolic risk factors at baseline, and about 80% of the patient in both the groups had insulin resistance, And the median cap was 325 in the yoga group and 332 in the exercise group. And the median MRI PDFF was 16.4 and 17.3, which was comparable. And the median LSM was 5.7 and 5.9 in both the groups. So this is the primary outcome, improvement in hepatic steatosis at 6 months. As we can see here, the median cap improved in both the groups significantly, but the delta cap improvement was seen more in the yoga group, -47 versus -27, which was significant. And the percentage of patients who had improvement of steatosis by more than one category was seen in about 58% in the yoga group and 27.3% in the exercise group. However, there was no difference between the resolution of steatosis, and the median MRI PDFF improved in the yoga group alone significantly, which was not seen in the exercise group because of the limited number of the patients likely. And more than 30% reduction in MRI PDFF was seen in 40% of the patients in yoga group as compared to 10% in the exercise group, which was significant. So coming to the secondary outcome, we performed regression analysis to look for factors causing more than 10% improvement in CAP, but the group, that is yoga versus exercise, was not significant. Mean LSM reduced in both the groups with no intergroup differences. However, the clinical significant improvement in LSM, that is more than 20%, was not significant between the groups. The mean ALT reduced in both the groups with more delta ALT reduction in the yoga group than the control group, and the mean fast reduced in both the groups with no intergroup difference. The mean body weight and the mean waist circumference reduced in both the groups with more delta body weight and more delta waist circumference reduction in the yoga group than the control group, and the number of patients achieving 10% weight loss was 18.2% in the yoga versus 3.6% in the control group, which was significant. Triglycerides and HDL improved in both the groups with no intergroup differences. Mean HbA1c improved in both the groups with no intergroup differences, but mean FBS improved only in the exercise group and did not improve in the yoga group. The mean fasting levels and mean home IR also improved in both the groups with no intergroup differences. The number of patients having improvement in metabolic syndrome were higher in the yoga group, that is 64% to 30%, than the control group, that is 65% to 42%. The mean LFI improved in both the groups with no intergroup differences. However, the hand grip strength improved in both the groups, but the delta hand grip strength improvement was higher in the yoga group than the control group, and none of the patients were frail at baseline, and the number of patients improving from free frail category to robust category was higher in the yoga than the control, and the number of patients having improvement in sarcopenic obesity was also seen to be higher in the yoga group. So the compliance was assessed by daily attendance of the yoga class. The average sessions and the average minutes per week were comparable in both the groups. So coming to the discussion, the significant challenge with lifestyle intervention is its poor adherence, implementation, as well as regain of weight after stopping the exercise. So yoga is a potential alternative solution to weight loss in MASLD. Previous studies have shown similar results in weight reduction and as well as improvement of insulin resistance. Our study shows that improvement in hepatic steatosis and body weight in both the groups with more significant improvement in the yoga group. So to conclude, that is 6 months of yoga with dietary calorie restriction is non-inferior to exercise with dietary calorie restriction in improving hepatic steatosis, reducing anthropometry measurements, improving metabolic profile, and improving frailty and sarcopenic obesity. However, further large multicentric studies are needed to confirm these findings and to explore the potential role of yoga for as a lifestyle intervention in MASLD. So coming to the limitations, that is the self-reported dietary compliance and exercise levels in the control group throughout the trial, and the long-term adherence to yoga as a lifestyle intervention could not be studied, and MRI PDFF was performed on a limited number of patients only. Thank you everyone. My special thanks to my mentor, Dr. Sunil Taneja, Dr. Arkade, and my head of department, Professor Ajay Duseja, and all faculties and colleagues at my department. Special mention to Professor Akshay Anand and his team at PJMR Yoga Center and all my study participants. Thank you.
Thank you, Dr. Balaraj, for a wonderful, wonderful study. We'll have one question. Dr. Agrawal, please.
So, two questions. Firstly, this was a non-inferiority study.
Yes, sir.
For that, what we need to see is what was the difference between the two groups and what were the confidence intervals of that difference, and how does that compare with the non-inferiority margin? We didn't see that at all in your slides.
Sorry, sir. I could not show that.
So what was the non-inferiority margin?
Non-inferiority margin was 25%. It was 0.25 one-sided.
Sorry?
0.25. Non-inferiority
0.25. But your primary outcome was change in steatosis.
Improvement in hepatic steatosis.
So that was on the cap, right?
Caps.
So what does 0.25 mean in cap? Second question. A basic problem with non-inferiority trials is if both the treatments don't do anything, there would be non-inferiority. Are we sure that exercise did anything, or was it purely the effect of dietary restriction? If I say that exercise didn't do anything at all, it's not neither exercise nor yoga. So anyway, that's a basic problem of this design. So ideally, one would like to have a third group where neither of the two is given.
Yeah, I just want to say that nowadays for the exercises when we prescribe for MSLD, we ask for both aerobic and strength training. But your studies has not included strength training. So can that be the cause for the difference in the outcome in yoga group and the exercise group?
Ma'am, with the thing which was not shown here, we have also calculated the metabolic equivalence of the task done. It was lower in the yoga group compared to the exercise group. The exercise group also had higher number of mets, and though the patients in the exercise group had lost less number of weights, the number of patients who had achieved more than 5% body weight reduction was higher in the yoga group. That is 65% and 47% in the yoga group.
What I mean to say, when you combine both,
Can
see
we,
exercise,
Exercise as well as
Can
resistance exercise.
Can we stop here because it's interest of time? Thank you so very much for a wonderful presentation. I think we had 5 great papers today.
Thank you.
Each one is relevant, and I think all 5 of them are make a good publication. With that, medical all of them, and I'd like to close on
Thank you,
behalf of
sir.
all the judges and chairpersons of this meeting. I'd like to close this session and hand over to the organizers. Thank you so very much.
Thank you, sir. May I invite all the speakers and the chairpersons for a group photograph, please?